Good afternoon again, everyone. We're going to give it about another minute to fill the room here.
Is my arrow visible, Brett?
Yep, I can see it, Dr. Gupta.
All right, great. This is much better because the laser pointer, if I use it, then I can't use my mouse.
And we'll give it about another 30 seconds, everyone, to fill the room.
So you can see the audience.
Yes, yes. All right, so good afternoon, everyone. Thank you again for joining us for our weekly Wednesday webinar series. Today's webinar is on the science of pain. And my name is Brett Spitali, and I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenter after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, November 12th. Today, we will also be live streaming on our LinkedIn and YouTube channels. I'm joined today by Dr. Gupta of the University of California at Irvine. Dr. Gupta, thank you for taking the time to join us today, and I'll now turn it over to you to get us started.
Thank you for inviting me to speak to this elite audience of the community, as well as caregivers and scientists. I'm honored to be here. I will be speaking on a subject which affects most of us, pain. But we know when we feel the pain, but what do we know about it? And what I'm going to tell you today is not only what I have learned from the literature or what I have researched, but what I also feel. And at the moment, I feel the pain of not being with my audience, because that's what I'm used to speaking to. I'm speaking to my computer screen, and that is really painful, I think. But then I think of all the pain that comes with multiple conditions like hemophilia and others, and I feel that this pain is nothing. We can overcome this, and there is a larger advantage to this pain, and that is that we can reach out to many more people and take advantage of the system. I'm not able to move my slides. Okay, now, here are my disclosures. So what is pain? Pain is like a big elephant in the room and three blind men who each could represent easily a scientist, a caregiver, and a community individual. Neither of us know really exactly what we are dealing with. The scientists are still trying to figure out which side is the head and which side is the tail, whether to approach the brain or the foot for the pain. But pain alone, we know that costs our nation more than $600 billion a year, which together is more than what is spent on combined cancer, cardiac diseases, and diabetes. So this just shows us the magnitude of pain in terms of suffering, which can also be quantitated in terms of these billions of dollars spent. Why is pain supreme and more important than any of the conditions? I do not undermine those conditions, but why is pain more important? Because it impairs the quality of life. It affects us every day. It comes with cognitive impairment, anxiety, depression, feeling of isolation, stigma, emotional distress. It affects self-confidence. Children lose their school days, affects our mobility. And therefore, there is a critical need to overcome these while one or many medications which people use. Why? Because pain is not a disease which originates by itself. It's in most cases the sequelae of a primary condition like sickle cell disease, cancer, or hemophilia in this case. Why is it that For centuries, people have suffered with pain. We have made strides in chemotherapy. We have made strides in dealing with cardiovascular disease. But why are we so much behind in dealing with pain and understanding and treating it? The reason is that it is not one system. The nervous system is the complex system of wiring all over. If you look at the left-hand panel, it shows you a very clear-cut skeleton. You can define it so easily. I do not mean that it's less complex, but when you look at the right side, and I made it deliberately fuzzy, this is how we understand our nervous system today. It is fuzzy. And brain, the powerhouse, is even less known and remains a big mystery. And how they interconnect with each other and respond to the environment adds even more complexity to this overall entangled network of nerve fibers running from head to toe. Now, in order to understand this fuzzy system, we tried to simplify it by making these cartoons. And here I would try my best to explain this A to Z of the pain circuitry. And I call it one of the most complex orchestras. And so on the left-hand side, I'm showing the flow of events that occur in pain. So at the bottom, we have a part of the brain, which is an extension of the spinal cord, but it is called a peripheral organ because it is not located inside the spinal cord or in the brain. This dorsal root ganglion, or DRG, receives signals from the organs like skin, foot, hand, everywhere in the body, and then it transduces them, and this converts the noxious stimuli to action potentials, and they are transmitted to the spinal cord. So this peripheral nervous system involves our different organs, skin, which has a lot of nerve terminals, and the dorsal root ganglion is the house which collects all these signals from these different parts and then transmits them to the spinal cord. Now, spinal cord is one of the most important parts in this system. The reason being, it connects this peripheral system to the brain, the powerhouse. And spinal cord transmits the signals to the brain, but it also receives signals from the brain. Now, this is a very important part of pain perception. The reason being that brain is the mighty part of the central nervous system. It has the power to actually modulate these signals by its own perception from outside, from the environment, from touch, from many other things. And therefore, this becomes even more complex. Now, these signals are electrical as well as chemical. There are action potentials and there are chemicals which are released in turn in each of them. And what we call these signals which are released externally, noxious or painful signals. So here is the other cartoon which shows the flow of electrical and chemical stimuli or components from different parts of the nervous system. So here at the bottom, we have the peripheral part, which I showed you here, analogous to this. And here what happens is there is an exchange of ions. Whenever there is noxious insult, there will be an increase in sodium and calcium. This leads to electrical impulses in terms of action potentials. And they go from the periphery, say, for example, from the skin, to the dorsal root ganglion. And what happens is these nerve fibers are very, very long. They can be miles long. And they end in a body, which is like the house where the neuron body is sitting and sending out these podias, like an octopus who sends out its arms all around and sits at the bottom. But this octopus has two arms. Each neuron has two arms. One goes into the spinal cord and the other goes into the periphery. And here in this DRG, these action potentials are amplified. And then they are further modulated depending upon what is being released, what is being affected. And then these action potentials that travel to the spinal cord. And in the spinal cord, there is a gate in the dorsal inner part, which is like two shoulders extending out from the spine. And there they receive the signals from the brain. And when they receive these signals from the brain, the signals coming from the periphery as a result, say, of a disease modulation, they are modified. So whatever is released, say, substance P, which is a neurotransmitter, and a signaling pathway, which is activated, say, phospho-P38 MAPK, these two are actually mediators of chronic pain. And when they are released, these can be modified by the cues, by the signals coming as neurochemicals from the brain. And therefore, it is called the gate. Gate is open or gate is closed. And then there is further modulation. And then these signals then travel to the brain. And brain has the power to perceive the brain or make us feel what we feel, the unpleasantness, the uncomfortable feeling, and all the suffering that we believe in. And so it is perception. So the perception comes from the brain. But then what happens in the peripheral and the central nervous system here, in the other two parts, is that the peripheral parts not only convey the signals, when the signals get too much, they keep going. Everybody gets on an autopilot. And they start throwing out their own signals and chemicals without getting a stimulus. And it's called the antidromic release, or in the opposite direction. They start sending the signals back to the periphery. And the periphery does not have to receive the signals anymore. They start acting like they are being stimulated from the external sources, but they're not. They become self-adapted, or they get on an autopilot, or in scientific terms, we call it sensitization. So we call it nociceptor sensitization. So this nociceptor sensitization occurs, and then it puts the whole system on an autopilot. And then the same thing can occur in the neurons, which are called second order neurons, which are sitting in the spinal cord, and this can cause central sensitization. Now, when this central sensitization occurs, it is very difficult to treat pain. It happens in chronic pain conditions when the stimuli are continuous, such as can occur in a congenital disease like sickle cell disease, where the noxious stimuli start very early in life, and they continuously are attacking the central nervous system. So this central sensitization is very critical because it makes pain refractory to therapy. We can keep giving opioids and we can increase keeping opioids and it doesn't respond. So I hope with this, I've been able to at least provide some knowledge of different components to everyone. And I will try to keep it simple so that everybody can understand. Now, the most important question here is, when we say that the system is activated, what activates it? I mean, why doesn't it happen to everyone? Why does it happen to under certain conditions? We know from various disease states where there is pain that there are so many phenomena that could affect the nervous system directly or indirectly. And there is a long list, and I have only included some, which are also relevant to hemophilia because of hemolysis, cell-free heme, hypoxia. There might be ischemia, reperfusion injury. There is inflammation, oxidative stress, vascular dysfunction. The vessels are leaky, organ damage, and there are some conditions, other blood disorders like sickle cell disease, where there are chronic wounds, vasoocclusion. In cancer, there is metastasis. There's osteoclastogenesis in several conditions, and possibly hemophilia, fractures, and all these can stimulate the nervous system at different levels in the periphery as well as in the central nervous system directly or indirectly. Now, how can we target pain when I'm presenting such a complicated picture? So first we have to divide it. What are we asking? How can we do it? So the first thing is that there is a disease. As I said, pain is a consequence of an underlying condition. Say, for example, here I give the example of sickle cell disease, where the red cells are sickled and they occlude the blood vessels, causing the worst pain almost known to mankind. But we understand sickle cell disease. We have been researching on it for more than half a century. 3/4 of a century ago, it was described as the first genetic disorder. But we still don't know how this causes pain. So the first question is to ask, how is the underlying disease causing pain? Because this will also affect how we treat, because this will be different for different conditions. So on the basis of this, I would say first strategy is prevention, and the next strategy would be treatment. So in prevention, what we can do is we can either stop or prevent or treat the disease so effectively, like gene therapy is becoming very common nowadays, that this does not activate the nervous system. Or we can find these mediators which are used in the activation of the nervous system by the primary condition and stop those phenomena. And that would prevent the pain from being evoked. But this is being a little unrealistic. But what is more realistic is that once the pain is there, then we need to know how to treat it. Now, these can be interrelated and overlap as well. But one thing to understand is, can we prevent it at source before it starts? Because as I explained, once we get into central sensitization, it can be more challenging to treat and it can be a lifelong phenomenon. So that is why it's important to understand these two, prevention and treatment. With this, I would like to move further and show you how the brain is the master regulator and how can we, in spite of the disease, control it without the interventions of the periphery. And this is a treatment strategy, as well as nowadays it is shown that when we manipulate the events in the brain, they also have an impact on the peripheral systems or on the disease. So here there are three important components in the brain, higher centers of the brain, in different regions, PAG, PONS, and in the RVM. And they release these chemicals called dopamine, which is also called a chemical for happiness, and then norepinephrine and serotonin. And these are the chemicals which go into the dorsal horn of the spinal cord and have the power to override the effects or the phenomena that was activated by the disease. And that is why, and there is very little known about this as compared to the peripheral phenomena. So it's very important to understand this because this can help us in an everyday life and activities. Now, what are we using for centuries to treat pain? Opioids. They remain the mainstay in spite of many known side effects. And I won't go into this, but our lab has also researched and found many others like opioid tolerance, pruritus, vasodilation, renal injury, retinopathy, but they can also have a good effect on wound healing, and vascular permeability may be implicated in stroke. And these are all based on multiple preclinical and research studies and also some clinical studies. And in spite of that, we continue to use these. Why? Because we have not been able to develop a uniform analgesic to treat pain once it has occurred. Now, going from this to pain and hemophilia, and I must say that I would treat myself as a student at this moment because I do not know much about hemophilia. So this is my disclaimer. Now, I would try to bring some of the points that can influence how we go about it in the future. So pain in hemophilia, despite the high prevalence of recurrent, constant, or widespread pain, there is very poor understanding, and it will be an understatement to say that we have really not initiated studying pain in hemophilia. And understanding the complexity of pain allows to better assess and manage pain. So we need to do this. And unsurprisingly, a significant proportion of patients with hemophilia report that their pain is not well managed. This doesn't mean that the efforts are not there. Undertreatment might have serious consequences. And as I said, that once it becomes chronic, it's refractory and it's difficult to treat. And it will influence the quality of life and increase suffering. So, and it's very well known that it causes suffering. It affects daily life in hemophilia. In one of the surveys of 71 patients, an average of 4 painful joints, activities of daily living were limited in 89%. Mood was affected negatively in 85%, and untreated persistent pain was reported by 50% of the patients. That's a lot. Arthropathy causes changes in joint condition, decreased range of motion, proprioceptive biomechanical and gait disturbance, atrophy of the periarticular musculature. This is a lot of physiological morbidities. As a consequence, patients report chronic pain and loss of functionality, which leads to a disability that negatively influences the perceived quality of life. And also, lo and behold, this can start very early in life because of the inherited nature of the condition. And there is a pain classification in hemophilia, and it is important in the evaluation of the predominant pain mechanism, as the treatment approach will be very different according to the underlying pain mechanism. This does not tell the mechanism though. This is a broad classification that is more and more used in patients with musculoskeletal pain, but not in hemophilia pain. It's the differentiation between nociceptive, neuropathic, and central sensitization. Now, nociceptive pain refers to pain originating from actual or threatened damage to neural tissue with activation of nociceptors, which means like there is joint injury in hemophilia. So that would activate, that injury will activate the nerve fibers in its vicinity that will evoke pain through the orchestra I explained. Now, neuropathic pain is defined as pain caused by a lesion or injury to the nervous system itself, to the nerve fibers, to the neurons. Now, the term nociceptive pain is used to describe pain occurring with a normally functioning somatosensory nervous system, which means that the nerve fibers are not damaged, but this can be observed in neuropathic pain. Why? Because when there is noxious insult, as we call it, when the injury is going persistently through the pathobiology of the disease, or as I would show a little later, then these nerve fibers will become damaged. And so they can coexist, the nociceptive and neuropathic. There are modalities to treat them individually with some emerging medications, but it's very hard to figure out what is nociceptive and what is neuropathic when the pain crosses some barriers. And then there is also a central sensitization issue. And not included in this description in this paper was inflammatory pain, because inflammation always increases whenever there is injury. The immune cells rush to rescue and they release cytokines, causing a cytokine storm, and which can then evoke inflammatory pain. So the question now is, how can we improve pain management in hemophilia? First of all, we need to understand the pathobiology of hemophilia specific pain. How is it being evoked? To actually, if you think of my cartoon, to prevent it or to stop it from being evoked. And then, and we need to know, how is it evoked? How does it evolve over the course of time? It is important to know whether it is going to or whether it has caused central sensitization. We need to characterize the pain. We need to know how to characterize. develop mechanism-based therapeutic targets to prevent or to treat pain. And then before we start treating it, we need to know how much pain are we treating. We want to make our coffee sweet. We need to know how much sugar we need to add. And here, how do we quantitate? We don't know yet. So we have to have tools to give it a number in an unbiased way and develop clinical management strategies. And I wouldn't go into that. So how do we do this? First of all, we cannot just go and do any intervention in a human being, particularly with suffering. And so we can develop mouse models of pain. And there is a very good mouse model of factor VIII gene knockout, which is used by many investigators. And they show constitutive and evoke bone changes and bleeding in the joints, representing clinical features of hemophilia. So we believe that these factor VIII knockout mice will also show the features of chronic and evoked acute pain in a microenvironment, which will be replete with free heme, inflammation, neuroinflammation, oxidative stress. And once we find that out, we can deal with individuals or we can find common targets. So here is a little hypothetical cartoon we have prepared based on whatever understanding we collected from the literature. And in hemophilia, we know that there is arthropathy, there is damage to the joints, and there is hemorrhage. Now, when this happens, what will happen? It will activate the nerve fibers. And this is just a remake of the cartoon in a more simplified way. It will then start sending the signals from this joint to the DRG, to the spinal cord, and to the brain. And is the person prepared to deal with it? And that's where the neuromodulation occurs through the environment. Now, what happens in this joint? Why is it transmitting these signals? And what are these signals? We do not know. But we believe from what we know that there is an increase in macrophages, there is increase in leukocytes, there is mast cell activation whenever there is injury as first responders. And since it affects the bone, there is release of osteoclasts. And all these, and then the synovial fluid. And what happens to the red blood cells? They start lysing. There is vascular leakage. When they lyse, they release free iron, and that can cause oxidative stress. And it will cause the death of or chondrocyte apoptosis, which means that the good cells are not being made or are disappearing, and then the bad cells or the osteoclasts are being released, which will cause further damage. And then there will be a whole big cytokine storm. So there's oxidative stress, there could be inflammation. And because these peripheral nerves are being activated, there will be neuroinflammation. They will start releasing substances which are neurochemicals like substance P, CGRP, peptide Y. And all these together will then travel and then activate the action potentials. And then the same phenomena can occur here and the pain will be perceived. Now, we do not know that all this occurs. This is our hypothesis. So what are the key questions and where do we start? As I said, we don't know. So first of all, we want to know, maybe in this model, is there constitutive chronic pain? And can we evoke acute pain by knee joint bleeding? And we believe that knee joint bleeding will evoke pain. And will this acute pain, this is a very big question, not only in hemophilia pain, but in overall pain, does acute pain and how transitions to chronic pain? So bleeding induced cellular, and then we want to know bleeding induced cellular and molecular noxious microenvironment in the periphery and the central nervous system. It will not be limited only to the periphery. And that is why we need a model so that we can know what is happening and how is it being transmitted and where do we stop it. And all the list that I just showed of the substances in different regions of the whole body. Now the question then comes back to how do we measure pain? How do we measure pain? So, in mice, and this actually we characterized sickle mice first for different features of pain. And then those were then used to develop quantitative sensory testing in humans. And that is being used widely, mostly right now for research purposes in sickle cell disease, but it is becoming widely applicable. So for which is what is relevant to hemophilia pain is mechanical hyperalgesia, which is sensitivity to touch. So if the joint is hurting, whenever we touch it, it'll be very painful. But the pain doesn't remain confined just to the joint where the events are occurring. It radiates all over. So there are fibers which are called von Frey fibers, and these tests are also used in humans. So it is for both, where we apply the fiber, in raw terms we can say we can poke the fiber on the foot pad, and then we see how many times the person lifts or the mouse lifts the paw, and that the more the pain, more will be the withdrawal. Then there is grip force, and the gripping power will depend upon if we are hurting and somebody is pulling our hand, it will hurt and we will leave their hand. We will not let them pull. So this is called grip force. And there is equipment which is fairly simple for both humans and mice, which can be used. And it gives a numeric figure. So we know there is no bias of the observer or the subject in describing it. Then there is motor performance. This is done on a rotor rod, but it can also be done in various other ways to determine in people if their motor performance is impaired. And then similar to Auscher scale in people, where we look at the facial expressions and then code and use action units to say how much is the pain. In mice, we call it mouse grimace scale, which is based on how their nose is bulging, how their cheeks are, how droopy the eyes are, which is similar to Auscher scale. And then there is gait, which is very important, I think, in hemophilia. And then we have developed a mouse walker system where we let the mice walk normally like they would be walking. And then using multiple cameras, we can acquire their footprints and also different parameters of their movement. And we can determine their gait. Similar equipment and similar modalities are actually available for people. And this is a very good way to gauge the changes over time because it is non-invasive, nothing is done, it's just observation by the machines or the platform on which they are walking. So these are some of the methods which are not being used, but have the potential to do semi-quantitative or quantitative testing in people with pain, with different conditions, and definitely in hemophilia. So looking up the literature, I found this very, very nice, very elaborate, very comprehensive study done by Michelle Whitcop and many other caregivers throughout the United States. And they have shown how do they formally measure pain in hemophilia, in blood disorders. And these are the various ways, this is the tools, they call it, are being used. Numeric rating scale, verbal rating scale, brief pain inventory, which is a good way, face type rating scale like Auscher, and scale based on function. Now, in all of these, there can be an observer as well as the subject bias. And it's not to say that there is a bias, but there is potential. And also to have a more simple way of assessing and a more a less subjective way, an objective pain measure would definitely help in routine care as well as self-care. Now, we have been talking about the perception. So now the question is, we know that we need to develop better methods to measure pain. We need to understand them, but what can we do now to feel better? We know it takes years to do anything new and bring it up for everyday use. Can we change the perception? How? And that's why I talked about the brain as the master orchestra. There we can take help from integrative medicine, which is a combination of medical and complementary therapies. Now, it should not be confused that if one is using an integrative complementary therapy, they have to stop their medical therapy. But it should be based on scientific evidence, because there is a lot out there which, which is scary. So one has to be very careful, and 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 always consult their caregivers, and always consult about the authenticity of the products if they are using, or of any intervention which is integrative they are using. So in order to give more credence to what I just said about perception based, we did a small experiment in mice which have sickle cell disease. It is another rare blood disorder in the United States. It is also genetic. And we started working on it about 10-15 years ago. And what we did was we tried to make the mice happier, their environment happier. So we gave them two different kinds of diet: a rodent regular diet, which is generally given to all the mice. But in sickle cell disease, their energy requirement and their nutritional requirement is high because of many reasons. So we enriched this diet, calling it sickle diet, with more minerals, more amino acids, vitamins, and we also incorporated omega-3 fatty acids. And as a result, we increased the protein and fat calories. Now, this fat was from omega-3 fatty acids. Now, this was done to provide them more energy, because there's more energy depletion in sickle cell disease. And then what we did was we divided these mice further into three groups. We actually divided them into many groups, but showing here only three important groups. One we called a deprived group. This group was fed, and now this study was only done on male mice. So in the deprived group, we fed this male mouse a rodent diet, regular diet, and kept them alone in a cage without any other mouse. And for happy mice, we fed them sickle diet. We fed this mouse sickle diet and kept this male with a female for 6 to 8 months, one male and one female in the cage. We could not keep two males because of pain. They fight and they injure each other. So that is why we had to keep a female in the cage. And for the unhappy mice, we took the group 2, which was fed sickle diet, and the male was with a female for 6 to 8 months. And then we suddenly withdrew both. We withdrew the female, left the male alone, and we started giving them the regular diet. Let's see what happens. So here I showed two things. One is I'm showing the serotonin levels. Serotonin is released from the brain, as I showed earlier, from the higher brain centers, which is based on perception, and goes into the spinal cord. So we measured the serotonin levels of these three groups of mice in the spinal cord to see how much serotonin they had. And then we also measured pain in these mice. This is after 3 weeks of this treatment, of the withdrawal treatment, and then 6 to 8 months of this treatment. And what we find is that in the deprived mice, where the male was alone without a female and getting a poor or unnutritional diet, had the highest pain. When we supplemented the diet of this mouse, of this male, and also incorporated a companion female in the cage, the pain went down. But when we withdrew both of them, which was traumatic, the pain went up and the serotonin levels went down. So the serotonin levels were down when the pain was more. Serotonin levels were high when the pain was less. And serotonin levels were low when the pain was high. So this just shows that the environment, and this is very unbiased, mice can't speak, and we measured their pain using 5 different methods. And here I show only one of them, which is mechanical hyperalgesia or sensitivity to touch. Now, this shows that the environment matters and integrative approaches can be helpful. And there are several papers where they have shown that in chemotherapy treatment outcomes, that people suffering with pancreatic cancer who had stable relationships responded better to chemotherapy outcomes. And then in sickle cell disease, it has been shown that pain and pain-related cognitive and affective variables are associated with daily variation in opioid use. And this happens because daily opioid use fluctuated as a function of pain, catastrophizing, and affect in patients with sickle cell disease. So if one is happy one day, they need less opioid. If they're unhappy one day, something traumatic happens, they need more. So we have to be aware of this and prevent unforeseen circumstances or things that can uh, have an effect. And similarly, there was another study which showed affective modulation influences opioid analgesia in sickle cell disease. Now, are we using non-pharmacologic complementary approaches? And I see that in this very nice, very comprehensive paper from all the centers in the United States, again, Michelle Whitcop and colleagues have shown, and this is just a short list, but it's a very big list, that so many therapies are being recommended at multiple levels by therapists, social workers, distraction, acupressure, aquatic therapy, mindfulness, alongside surgery or splints or braces, yoga, acupuncture. So this is very good to know that these are being used. It would be very nice to see how they are influencing a person individually. And it's not just us. Actually, now NIH, through their HEAL initiative, and I will introduce HEAL initiative to you in a minute, they are trying to test a modified electronic health record system to help patients express interest in complementary health treatments for pain. And it is felt that these approaches can be effective treatments for pain. But while these approaches like chiropractic care, meditation, Tai Chi yoga have been shown to alleviate some types of pain, doctors don't always know how to provide them to their patients. This is something that is becoming more and more well known, and this is taken from the website of HEAL Initiative. And I attended the second HEAL Initiative investigators meeting, which was actually conducted by Francis Collins, the director of NIH, and he and Vivek Murthy, the Surgeon General, they emphasized and discussed the harms of social isolation for vulnerable populations. So this blends very much with the experiment I showed you, and that was the reason that I showed it. And they ask for the need for compassion and the importance of connectedness. And what in our work we have provided is the mechanism, how it occurs through the brain. Now, the question now is, how can we harness the power of brain? There is hope right here. There are mechanisms of pain in vivo from remote access that can be tested, that can be observed using sensor-based technology, which is in process. But I am hopeful that will be there. And can we use, we can't enter the brain, but can we use the brain on the bench? So through stem cell engineering, those efforts are on the way. Neuromodulation for treatment, because there are so many drugs being used. Can we do a drug-free treatment? And these are non-invasive technologies like transcranial focused ultrasound. We are working on this with our partners at Carnegie Mellon University, Dr. Bin He, who is an expert in it. And as we speak, we are working on it in sickle mice and in primates. And then can we quantify pain without any observer or subject bias? We have standardized this with Bin He again using quantitative EEG, and a commercial enterprise is now doing clinical trials. They have developed it further. And can we view pain normally while walking? And there are machine learning applications which we have used and which are going to become widely applicable for determining gait, which also correlates with pain. What is the journey forward? And I'll give you an example that, and I would be very short. We started this journey in 2010. This was the first paper published on sickle cell disease mechanisms by us. And it came with a commentary, New Era Dawns on Pain in Sickle Cell Disease. And we showed that the nerve fibers are damaged. This firecracker kind of event you see here in turquoise is actually the nerve fibers damaged in the skin, throwing out these firecracker-like structures. And from there, we then published a clinical trial on vaporized cannabis's effect in subjects with sickle cell disease chronic pain. We could not complete the whole number that we needed, but with the limited number, we did not get statistical significance, but we can show in the pain interference ratings that there was improvement. There was lesser and lesser pain on day 5 after treatment, improved general activities, improved mood, which was significant statistically, improved walking, normal working, sleep, and enjoyment. So where are we today? In more than 10 years or 10 years, what we started has led to many interventions, both integrative as well as pharmacologic, based on modulating the central nervous system or modulating the events in the peripheral and the nervous system. So what we need to do, we need to develop a system-wide approach where we need to learn the mechanisms, use molecular cellular biology, histopathology, electrophysiology, chemistry, and then develop methods to quantify pain and have approaches which include environment, integrative approaches, whatever we know about cannabinoids, optimize opioid analgesia, and develop new therapies, pharmacologic as well as science-based. And this is the Helping to End Addiction program, which has been in place since 2018 to 20, and it's still ongoing. It is called Helping to End Addiction Long Term. It's an initiative to develop better pain management and treatment strategies and discover new approaches, new therapeutics to treat pain. And we need to take advantage of this. Many diseases fall under this, but I do not see hemophilia. So where are we? We are starting, and we have miles to go before I sleep. I would always remember Roberts. And I would like to thank my team who has helped me come to this stage where I could be speaking to you, and NIH and other funding entities. And I thank you very much for being there and for inviting me to this event. Thank you.
Thank you so much, Dr. Gupta. We appreciate your expertise here. And we do have some questions that have come in, and I'm going to start with this one. And it asks, there's been basic science research on pain in sickle cell, but what about in bleeding disorders?
Sorry?
Sure. The question is, there's been basic science research on pain in sickle cell disease, but what about in bleeding disorders?
What about in patients? Yes, there is a lot of ongoing research in patients. And actually, as we speak, 2 RFAs have just come out last week to see how we can implement some of these strategies. And what they have realized, there is no new pain treatment that can be administered, we know this, but in sickle cell disease, they have discovered that they can improve hemoglobin by using voxelotor, a hemoglobin inducing agent. They can reduce the VOC events by using an antibody to P-selectin, and it was FDA approved in 2017. In 2018, another drug, glutamine, which is actually a supplement, but this glutamine is prepared specially for sickle patients. It also reduces the events of VOC, but none of these reduce chronic pain. And then the efforts are ongoing at a very, very fast level and with high intensity to develop gene editing and gene therapy for improving the sickling or reducing the sickling of the red cells and increasing good hemoglobin, particularly fetal hemoglobin, which can override the effect of sickle hemoglobin. So these would be preventive strategies, but what they have found is that when they have done bone marrow transplants, some patients still continue to have pain. And this could be the reason, as I showed, this firecracker effect on the nerve fibers. These cannot be repaired. And our lab has found out why it cannot be repaired. Because the repair mechanisms are downregulated early on in sickle cell disease. And the mechanisms that actually cause injury are upregulated. So the balance is shifted from being a promoting or a balanced environment towards an injury-inducing environment, and injury preventing environment is compromised.
Great. Thanks, Dr. Gupta. Next question that comes in, how can organizations such as NHF foster or support pain science research?
Well, any research is very expensive. When we talk about research, we talk about millions. And I think NHF is very supportive, I think, and it is initiating, and because of them, I'm here. And I think what the first and foremost requirement is to develop funding options. Without that, we cannot move forward. And what NIH did was, NHLBI particularly, and that's why I was a principal investigator of the hemoglobinopathies, Excellence in Hemoglobinopathies Research Award. They came out with this targeted sickle pain efforts. And they have been continuously now for 10 years being funding research just for sickle pain under different umbrellas. And now, as we speak, the HEAL program came out with 2 RFAs last week, and there are several others which will fit, which may even fit hemophilia pain for going forward. But the problem is that we have not initiated anything. And to be able to procure that funding, we need to have something that we have initiated and to provide the confidence that our hypothesis is correct. And that's where I think National Hemophilia Foundation can be very helpful.
Great, thanks, Dr. Gupta. The next question that comes in is from Lawrence over in the UK, and he asks about the general evidence base of medicinal cannabis for pain management. He says he understands it's widely used in the likes of the multiple sclerosis community and from some peers in the bleeding disorders community, but it does come with risks. Can you comment on that?
Yes, that's a very good question, and its answer can be very long. But it has to, first of all, one size fits all doesn't work. As I explained, for every pain, there is a different reason. Now, the cannabis is a very broad acting constituent. It has THC, it has CBD. THC has psychoactive effects. So that puts us under a limitation. And that is why when THC was developed for pain, they could not continue it. And it is instead used actually for alleviating chemotherapy-induced nausea. So as an antiemetic drug. So for THC, it will be hard. But in cannabis, there are many substances which can override the effect. They do make the people feel better. And as we showed in our trial, we found that there was some beneficial effect, and it was only 5 days. Now, the problem is that these balanced clinical trials have to be performed before we can say it is effective. The other issue that has come up now with medical cannabis is much bigger than this. And the problem is that there are so many preparations all around. They're not certified. They are not validated. And what people are getting, we don't know. And every route is not, and which route to use. We used vaporized cannabis because of the liver infarcts. We didn't want to put any more drugs into the system. But people who have, say, lung issues and other things, they cannot use those. So we have to be very careful. And we need to really figure out piece by piece which preparation should be used, which is a reliable preparation, and which is not a reliable preparation, and then examine its effect in a clinical trial before saying that, yes, it would have a beneficial effect. It has definitely it has shown a very good effect in MS, and the pathobiology of MS is different, but there is a mobility issue there. So there's some features which are common, but pain is pain. But again, if we go to the left and the middle panels of my initial figures, how is it being evoked is very important.
Great. Thanks, Dr. Gupta. I think we have time for at least one more question here, and this comes in from Paul. He asks, do you have any experience with microfragmented adipose tissue transfer for ankle pain or lipogems?
From where?
Do you have any experience with microfragmented adipose tissue transfer for ankle pain or lipogems?
No, we don't have.
Okay, let me find another question here. So the next question that comes in, you are proposing several options for quantification of pain. How do those fit in with the biopsychosocial lens to understand a person's pain experience?
That is very important. And that takes us back to our affective modulation and environment. So unfortunately, we need to do that too. So, and quantifying pain when a person walks into the clinic, if they have a pain which is 8 or 9, you might like to give opioid. But if they have 3 or 4, maybe acetaminophen or ibuprofen can help, right? So that is why quantification is important, but for the overall well-being of the person, because the environment and all these affective modulations feed into pain and pain feeds into them. So doing both is required. And I fully agree with the question that yes, that is very important, and we need to understand that, and we need to improve that.
Great. Thank you so much, Dr. Gupta. I think we're up against the hour here. So I'd like to take a minute to thank you for being here, for joining us this afternoon. We appreciate all of your time and your expertise. This is a wonderful presentation and very active audience there. So thank you, Dr. Gupta, for joining us.
You're welcome. Thank you very much for inviting me again. And I hope we have a better day next time when we speak.
Yes, definitely. Definitely. So please note that this recorded webinar will be available on Friday, November 12th at hemophilia.org under the events tab with all of our other archived webinars. Also available in the events tab is the schedule for our upcoming weekly Wednesday webinars, and we are streaming from this point on LinkedIn and YouTube Live as well. Thanks again for joining us, Dr. Gupta, for all your expertise, and we hope to see you again on here. Take care, everyone.
Thank you.